Dear audience, dear chair, welcome on my 9 months progress report on my PhD thesis investigating the effects of biologics on the comorbidities and microbiome in psoriasis. My name is Mária Veronika Kolonics. I am a medical doctor and a PhD student in the Department of Dermatology, Venerology and Dermato-Oncology, Semmelweis University. I have a mission, which is a decreased disease burden in psoriatic patients, and I have a mission, which is finding the best therapy in psoriasis. I have 2 specific goals. In my first project, I would like to find out which biological therapy reduces most effectively the cardiovascular burden in psoriatic patients, while in my second project, I would like to examine the role of microbiome in the formation of therapy-resistant scalp lesions in psoriasis. The title of my first project is investigating the effects of biologics on the cardiovascular risk of psoriatic patients, and the methodology behind it would be a systematic review and meta-analysis. Psoriasis is a chronic recurring autoinflammatory skin disease with a world prevalence of 2 to 3%. In psoriasis, there is a systemic inflammation which involves not only the skin and joints, but also the cardiovascular system. In the pathogenesis of psoriasis, there are 2 very important pathways. The first is the interleukin-23 Th17 axis, and there are some other TNF-alpha-mediated pathways which are very, very important. These pathways are also dysregulated in the formation of atherosclerosis and cardiovascular diseases. In psoriatic patient population, the risk of major adverse cardiovascular events is higher, while the life expectancy is 5 years shorter. Psoriasis is considered to be an independent cardiovascular risk factor. Only 1 point elevation in psoriasis area severity index contributes to 4% elevation in cardiovascular risk. TNF inhibitors decrease the risk of cardiovascular events effectively, and this is an evidence which was published by your research team. But besides TNF inhibitors, there are some other novel biologics which are targeting the interleukin-23 Th17 axis, and these biological agents becoming more and more widespread. But the relative risk-reducing effect of these anti-psoriatic agents remains still unknown. Our aim is comparing the effects of biological therapies on the risk of cardiovascular events in psoriasis. We would like to examine patients who have psoriasis, and we would like to compare the effects of biological therapies on the incidence of cardiovascular events. A clinical question sounds like, which biological therapy reduces the cardiovascular risk in psoriatic patients most effectively? Our hypothesis is that interleukin-23 Th17 axis inhibitors are superior to TNF inhibitors in cardiovascular risk reduction in psoriatic patients. The clinical implication would be choosing the most effective treatment for psoriatic patients who have high cardiovascular risk. Here you can see my finalized search key, and there was no similar registered Prospero, but there was a very novel, very similar systematic review and meta-analysis from last year. But in the methodology, interleukin-17 inhibitors were excluded, so as you can see, there is still an unmet need for conducting a project. Here I listed you some of my key articles. These are 3 RCTs reporting adverse event on interleukin-17 and on interleukin-23 inhibitors. Here you can see the journey of my selection. First, we had approximately 15,000 hits. After the duplicate removal, this number could be reduced to 11,000. And after the title abstract selection, we screened more than 3,000 articles, which you can see was a very demanding work. And currently, approximately around 200 articles seem to be eligible. But as the data processing progresses, this number might be a subject to change. Here you can see the progress of my first project, and we wish to finish the data extraction until July. Let me talk a little bit about my second project. It would be a prospective observational study, and the title is Investigating the Effect of Microbiome on the Therapeutic Success in Scalp Psoriasis. Psoriasis is a chronic autoinflammatory skin disease affecting 125 million people worldwide. 80% of these 125 million people experience scalp involvement, which means a serious loss in quality of life. Scalp psoriasis is often isolated, therapy-resistant, and is also a difficult to treat psoriatic area. In microbiome research, there is a term which we call alpha diversity, and it expresses the variety of species within a single sample. Research has found that in scalp psoriasis, both the fungal and both the bacterial diversity correlate with disease severity. We suspect that maybe not just alpha diversity, so we suspect that alpha diversity might be not just influence only the disease severity, but also the therapeutic response. And that's why our aim is to analyze whether the alpha diversity of microbiome has a role in the therapy resistance in scalp psoriasis. A clinical question is, how does the alpha diversity of scalp microbiome associate with therapy-resistant scalp lesions in psoriasis? We would like to examine those patients who have psoriasis and scalp lesions, and we would like to form two subgroups. In the first cohort, we would enroll those patients who show sufficient therapeutic response. In the second, those who have therapy-resistant lesions on the scalp. As outcome, we would like to observe the alpha diversity, which is mostly measured by the Shannon index. Our hypothesis is that higher alpha diversity of scalp microbiome decreases therapeutic response in scalp psoriasis. The research implication would be providing more information for future studies investigating the treatment of scalp psoriasis. Here you can see a brief summary on my two projects. We wish to finish the first one until the end of this year, and the second somewhere in the summer next year. Now, I would like to close my presentation with the words of Friedrich Nietzsche. The belief in truth begins with the depth of all truths in which one has previously believed, and I would like to thank you for your kind attention.
In your opinion, and based on those data that you have read, what do you think, interleukin-17 or interleukin-23 blockers would be more effective in the reduction of cardiovascular risk in psoriasis?
Thank you for your question. According to my current knowledge, I think interleukin-23 inhibitors might be a bit safer. And also there were some controversies around interleukin-17 inhibitors. So I think that interleukin-23 inhibitors might be the best choice, but I'm not sure, so we will have to wait until the end to find this out.
I'm really curious what definition you use for major adverse cardiac events, because I wanted to use this outcome for my study, but we just couldn't pull the articles together because the definition is so inconsistent. So what is your definition?
Thank you for your question. I think this is a really good consultation and a really good opportunity, because we had the same issue. And after that we had this issue, we involved a cardiologist into our project, and we discussed with him what should be done and how. And as major, when we talk about major adverse cardiovascular events, there is a classic definition, which is mostly used. It's a triad of myocardial infarction, ischemic stroke, and cardiovascular mortality. But there are some other extended MACEs, so these major adverse cardiovascular events MACE. There are extended ones, which include also heart failure, angina, hospitalization for this and that. We excluded those articles who use MACE as extended one, and we kept those who have the classical triad definition. And we also collect still those articles who aren't defined which MACE. But if it's written extended MACE, we exclude it. And additional to that, we collect also the subcomponents of major adverse cardiovascular events. So we collect also data regarding myocardial infarction, ischemic stroke, and also the cardiovascular death, which we also collect. And thank you for your question.
Thank you.
We know from the group meetings that you were working a lot on the selection, and I was wondering, what do you think is the reason for having so many articles after the title and abstract selection, but still remaining only with 200 after the full text? I mean, I think you were expecting having a lot more full texts that are eligible, right?
Yes, thank you for your question. It has two reasons. The first reason is that we created a very, very safe search key. We all know that psoriasis is a very, very common skin disease. So we have tons of studies, tons of RCTs, and also we shouldn't forget that biologics, I think the first biologics were used in psoriasis. So it is absolutely the disease of novel therapies. First, we have many, many articles on psoriasis. Second, we created a very, very good search key. I think it was very strong. We also incorporated the verb safety to find all the articles and to have all the articles which are RCTs reporting on psoriasis. So this is the reason why we had so many hits. But after that, we polished. First, we polished our outcomes according to what we already discussed in the previous question. And we also decided to exclude those articles or those studies in which concomitant systemic agents were allowed, because this could be some confounding factors, and that's why we were able to make our study more precise. And that's why we had this many, only 200 full text to the current state.
It's related to your second topic. You are saying, I mean, your hypothesis is that the higher Shannon index probably will decrease the disease severity in scalp involvement. But what about the clinical implementation? How can you increase the Shannon index?
By using some agents which are improving the microbiome. And this is a current trend also in dermatology, also in the cosmetologic lineage. We also, I'm not, I think I cannot mention any brand names in this context, but there are many, many companies who also incorporate microbiome modulation by...
Are these topical agents?
Yes. Mm-hmm. Yes, mainly topical agents, and also we would be also able to produce some probiotics or symbiotics. But first, I think we should understand first the local microbiome. And after that, of course,
systemic,
the
yes.
systemic.